figured things out, which is what matters. Okay, you can get started, Elvie.
Okay. Good evening, everyone. Welcome to the March 11, 2021 meeting of the Community Board 6 Health and Human Services Committee. My name is Elvie Barroso, and I'm the chair of the committee. This meeting is called to order at 6:36 p.m. Tonight, we are joined by Community Associate Brandon Burt. Members of the public, you can raise any questions or comments that you have through the Q&A feature of Zoom. If there is time following the committee's discussion, we will field questions from the public. Andrew Suresh has volunteered to take minutes tonight. Thank you, Andrew. You all should have received several emails from the board office with a link to a doodle sign-up sheet for minute takers at your community meetings in 2021. For your convenience, the link for this committee is also being posted in the chat right now. At the direction of the chair of the board, each committee meeting must have a designated minutes taker and a designated backup just in case. To eliminate the guesswork, make sure that you volunteer for as many slots on the doodle sign-up sheet as you can. If more than 2 people sign up for a particular month, the office will make sure to distribute the duties equitably and will let you know in advance which months you're due to take minutes. If you have not already filled out the doodle, please do so right now. The link to the doodle sign-up form is currently in the chat, so now would be a good time to fill it out. So we will now take attendance by roll call. Brandon will conduct the roll call.
Committee members, I will call your name and you will unmute yourselves. When your name is called, please say present. I will announce if there is quorum. Marty Barrett.
Present.
Elvie Barroso.
Present.
Dan Devine. Okay, I don't think Dan is here. Rich Mintz.
Here.
Raj Nayar.
Here.
Anju Suresh.
Here.
And Ronnie White. Okay, I do not see Ronnie here either, but we do have quorum.
Okay, so we will now adopt the agenda. The agenda for tonight's meeting was distributed ahead of time by the board office and is reflected on the screen before you. If there is no objection, we will adopt the agenda. Members of the committee, if you object to adopting the agenda, you may raise your hand through Zoom. Seeing no objections, the agenda for tonight's meeting is adopted. So we will now adopt the minutes. The minutes from the February 11th meeting were distributed ahead of time by the board office. If there is no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, you may raise your hand through the Zoom. Seeing no objections, the minutes from the February 11 meeting are adopted, and they will soon be available on the CB6 website. In order to conduct an efficient meeting, let's observe a few ground rules. No one may speak until granted the floor. Committee members, if you have a question about committee business or wish to make a motion, please raise your hand through Zoom. If you click the participants icon, the participants panel should appear and you should find the raise hand function there. If you still have technical difficulty, you may click the chat icon and relay your difficulty. The chat function should not be used for committee business or questions about the agenda topics. All such remarks should be made on the record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or state in writing information that was already stated aloud on the record during the meeting. When a committee member is given the floor to speak, I will identify you and you can unmute yourself so that you can speak. We are required by executive order to create a verbatim transcript of the meeting. So please keep your questions and comments succinct and germane to the discussion. Tonight's agenda, we have a presentation on mental health issues related to COVID-19. We have two presenters from the New York University. The first presenter is Dr. Aaron Relly-Ford. Dr. Relly-Ford is an assistant clinical professor and fellowship training director of child and adolescent psychiatry at NYU, and both the director of child and adolescent psychiatry and the associate medical director of behavioral health Sunset Terrace Family Health Center of NYU Langone in Brooklyn. He received his medical degree at NYU School of Medicine and completed his child psychiatry fellowship at the NYPH Child and Adolescent Training Program of Columbia and Cornell Universities. Dr. Relly-Ford's clinical research interests include telepsychiatry, racial health disparities in pediatric mental health, cultural psychiatry, pediatric psychopharmacology, effects of early trauma on development of psychopathology, child-parent psychotherapy, psychoanalysis, and dynamic and insight-oriented psychotherapy. Our second presenter is Dr. Obianoju, or Oju in short, Berry. Dr. Berry is the medical director of NYU Health and Hospital Domestic and Gender Biased Violence Mental Health Collaboration and assistant professor at NYU Langone within the Department of Child Adolescent Psychiatry. She is a graduate of Harvard Medical School, the Johns Hopkins Bloomberg School of Public Health, and Columbia University Psychiatry Residency and Fellowship Programs. She is an academic researcher and clinician with clinical expertise in early childhood mental health, women's mental health, and trauma. She is experienced in mental health research, public policy, and has worked with a variety of state and federal institutions, including the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, and the National Institute of Domestic Violence in the African American community. During her training, she led a citywide hybrid implementation effectiveness study on the evaluation of a mental health and intimate partner violence intervention with the New York City's mayor office to end domestic and gender-based violence. Dr. Berry's research focuses on implementation science, service delivery, and maternal intergenerational transmission and impact of trauma on child psychopathology. So please welcome our two speakers for tonight. Brenda?
Yes, just a moment. Who's speaking first, Dr. Berry or Dr.
I believe Dr. Relly-Ford going to go first, yes.
Yeah.
Okay, you can speak whenever, and you should be able to share your screen with your presentation.
I am sharing my slides, is that correct?
unless you're having any technical issues, in which case I can share.
Great, that's no problem. Thank you all. I'm really happy to be here to talk about some of the challenges that our kids have been facing during COVID. I'm really happy to be here to be as a representative of our Department of Child and Adolescent Psychiatry at NYU, and even more happy to be presenting alongside my colleague, Dr. Berry. So I'm just going to share my slides. Just give me one quick moment, and everyone is able to see?
Yes.
Okay, so I'll start off by talking a little bit about how things presented at the beginning of the pandemic. This is a slide that was put out by the McSilver Institute at NYU with some other partnerships that kind of talked about some of the things that we knew and didn't know, and things were fast changing early in the pandemic. What we did know was that countries were going on lockdown. We knew that kids and families were restricted in terms of their movements. We knew that kids were being pulled out of school. And we knew that there was on some level trauma. And so we started to see that PTSD or post-traumatic symptoms were coming to the fore. We didn't know too much in terms of numbers, but data started to come out that described that anxiety and depression were up and increasing in kids and adolescents. We also didn't know very early on how COVID was impacting groups from different backgrounds, different marginalized backgrounds, particularly minorities. And so there were challenges early on in collecting racially based data. And we were also starting to see medical consequences for kids when earlier on it wasn't clear that children were actually affected. So it was a lot that was unknown and a lot that was starting to be discovered. So there were a couple of early review articles that started to lay out general concerns. Of course, kids who were confined at home and away from school, they were getting less exercise. Everyone was cooped up in the home with their parents. While on some level it helps with the kids' routine, which was certainly the case for me and my family, there was increased contact that offered increased opportunities for play, but also friction and potentially abuse. Adolescents were really hard hit in a way that was somewhat silent because they were frustrated with missing regular milestones, graduations, proms, high school transitions, college transitions. And that was something that really wasn't highlighted as much. And then there were nutritional needs, because the kids were at home. A lot of kids, particularly in marginalized backgrounds, they relied on school to actually get food. And that was certainly a concern early on. So what we started to see in terms of some of the findings were that adolescents generally were less depressed than adults. The college students were more depressed than primary school students. And kids were starting to be more clingy, demonstrate more behavioral problems. And we've known this from before, but also certainly highlighted in the pandemic. Adolescent girls were more likely than boys to be presenting with depression and anxiety. And kids in the high pandemic areas were more hard hit. We did know that regular exercise was associated with less depression and anxiety. But this strategy was not really employed by parents to mitigate psychological problems. Parents were working and they were just trying to get the kids occupied. And so they chose media as the primary source. Essentially, there was not much information, but individuals who actually had more access to information and more knowledge specifically about COVID, they were less depressed, less anxious. Those that were given misinformation or less information, they were more prone to be more anxious. Optimism and lower worries in this context about being infected led to less depression. Supportive relationships were really important. Relationships with the community, pro-social actions were shown to mitigate anxiety and depression. There was little data regarding the meaning of staying home for those who preferred to stay at home just because they wanted to be safe. There was less anxiety, but those who wanted to do so to avoid judgment or for unspecified worries, they had more anxiety. And what we did see, and we did see a lot more data as the pandemic rolled on, kids with neurodevelopmental disorders, ADHD and autism, there was a significant negative impact given the lack of structure and routine that they ordinarily would get through their various agencies and activities at school and otherwise. The parents were hard hit, which certainly had a negative impact on the kids. There was unemployment, and I'll show some data later with regards to unemployment in New York State, but that was increased. And then there are challenges with childcare, the burden certainly more on moms than otherwise, leading to decreased income. And then parents working from home, on some level a blessing, but it was really challenging. You're managing work at home, managing kids, managing school. That's a lot of increased strain, more mental health challenges, substance use, and relationship challenges. There was some data that talked about the impact on parents. This one study that looked at exhaustion during lockdown in Italy showed that 17%, I wager that it's much more than that, had significant parenting-related exhaustion. And that was predicted by psychological distress, lower parent resilience, being a mom, fewer perceived social connections, single, younger children, large number of children, children with special needs. Another study looked at the way in which COVID-related stressors or stressors that were specifically present as a result of COVID, such as mood being low related to COVID, increased stress, relationship strain, health of the parents and children, and how that interacted with other factors. But having an increased level of those certainly increased one's perceived stress. Having more financial stress with anxiety and depression was increased with more chance for child abuse potential. But increasing support led to decreased stress and less chance for abuse, and increased COVID-related stressors and racial factors, meaning being in the context of an underrepresented minority, was related to increased stress, increased perceived stress. Now that leads me to an important study that came out in September, put out by the United Hospital Fund and the Boston Consulting Group, termed the COVID-19 ripple effect. And it essentially showed that COVID has led to really severe racially disparate repercussions on kids younger than 18. And the study period was from March to July of 2020 at the early parts of the pandemic. And it had some summary findings here. About 4,200 kids in New York State lost a caregiver. Black and Hispanic children experienced parental deaths from COVID at twice the rate of Asian and white children. And the consequences of losing a parent to COVID can really have some long-lasting effects, which I'll go over. So as I mentioned, this study showed that 4,200 kids in New York State lost a caregiver, which was about 1 in 1,000 children. Blacks and Hispanics were differentially affected. And as you'll see in this slide, 57% of those kids in all of New York State, not just New York City, 57% of those kids in New York State were actually lived in the Bronx, Brooklyn, and Queens, which are in areas that were highest concentration of housing and lower income zip codes. So 1 in 600 Black kids in New York lost a parent. 1 in 700 Hispanic kids lost a parent or caregiver to COVID, but it changes. 1 in 1,400 Asian children and 1 in 1,500 white children experienced a death of a caregiver. So there's a real noted disparity. And the question is, why is that the case? We have some ideas and some answers. People of color were certainly at a greater risk of exposure. They were living in crowded, multi-generational housing, using public transportation, and they were on the front lines in terms of work and high contact occupations. Certainly racial and ethnic disparities were pronounced when looking at compared to whites. And certainly in these communities, there are mental health and health and social inequities that certainly contribute to there being disproportionately affected individuals in these communities. So, of course, if you're losing a parent, you're going to have many long-lasting consequences, potentially entering foster care, financial hardship, certainly, and mental health consequences over time. And about 325,000 kids were newly entered into poverty as a result of job loss in 2020. And these are some of the figures that highlight some of the financial costs. Unemployment rate jumped in 2020. 40% of low-income workers lost their jobs. And these are just some comparisons with regards to New York City unemployment peak. US teen unemployment peak is really important because those individuals are supporting the household also. And loss of that income was certainly important, and particularly for the lower income families. So I'm just going to move forward and talk a little bit about another factor within these communities. Certainly, there is a new crisis of Black youth suicide. Blacks, as we know, based off of many structural factors within our society, are more prone to experience trauma, systemic racism, unemployment, financial and food insecurity, which can certainly lead to increased mental health burden. And, you know, historically, Black youth have had low levels of suicide, but as of 2018, suicide became the second leading cause of death in Black children 10 to 14, the third leading cause of death in Blacks 15 to 19. And for Black children under 12 years old, they were more likely to die by suicide than their white peers. And there are many factors that may be contributors, certainly lower rates of engagement and completion of treatment for depression. Those with suicide attempts who are Black are less likely to have been diagnosed with mental illness and even less likely to, after a suicide attempt, to receive outpatient treatment. Higher rates of firearms in those communities. The last two slides, I'm just going to cover just some recent data, and this is of all backgrounds. This sort of highlights a bit of the challenges during the pandemic. Individuals were not necessarily seeking medical care. ED visits decreased by 56% during this early coverage period. Non-emergent visits dropped, but visits for suicide ideation, suicide attempt increased by 100%, they doubled. And visits for evaluating abuse or neglect actually decreased. So kids were more vulnerable because these things weren't being reported at school. And then there was a study that just came out that looked at data from January to November of 2020, that it was by the Fair Health Report, which evaluated 32 million medical records and insurance claims for teens 13 to 18. What it showed was that overdoses, intentional self-harm claims, substance use disorders, claims for depression and anxiety, all increased substantially in 2020 compared to the prior year. The most significant spikes were early in the pandemic. The claims for females were even more. And the percentage of medical claims in terms of mental health claims actually increased. So I'll pause there and turn it over to Dr. Berry.
Thank you, Dr. Relaford. It was such great data that you shared with us about that information, and so rightfully important for us to understand the effects of COVID on our children, who are our most disadvantaged population. So thank you so much for sharing that. So you guys can see my slides?
Yeah.
Perfect. Great. So my talk is going to kind of build off of what Dr. Relaford shared, but mostly focusing on domestic violence during COVID-19 and the work that I'm doing as the medical director for New York City's Health and Hospitals Domestic and Gender-Based Violence and Mental Health Collaboration. And a lot of stuff that Dr. Relaford had pointed out, the discrepancies, the healthcare and racial inequities, really kind of feed into the rise that we're seeing in COVID-19 these days, and with domestic violence these days. Before I begin, I just wanted to give everyone just a brief primer of what I mean by domestic violence and intimate partner violence and family violence, as sometimes they're used interchangeably. Domestic violence is a catch-all term to really kind of solidify intimate partner violence and family violence. It really is to highlight the fact that family violence is really around marked people who are in your family. So sometimes child abuse would be relegated into family violence or elder abuse. And then intimate partner violence, it doesn't have to be somebody within the family unit. It could be a romantic partner or a dating partner. Or somebody who's married or divorced. But the idea behind family violence and domestic violence and intimate partner violence is that they all share the same notion of a range of coercive and abusive behaviors used to maintain power and control over another partner in an intimate relationship. In terms of intimate partner violence, and which can be also relate to other types of violence, I usually like to use a definition from the CDC, which says that intimate partner violence is characterized by physical violence, sexual violence, stalking, or psychological aggression, including coercive acts from a past or current intimate partner. Most people, when they think about intimate partner violence or domestic violence, they usually only think about the physical part, the hitting, the kicking, the choking, the strangulation, the threatening. But there's also sexual violence, being threatened or forced to take part in the sex act. There's a psychological violence, which are the name calling, the intimidation, the economic control, which is what we're seeing a little bit more during COVID-19, withholding money from the survivor, and the isolation as well, the social isolation piece. And also stalking, which is the repeated following or harassing of people. And what I'm seeing a little more now with COVID-19, the use of technology to stalk and monitor the survivor, in particular, like using the use of social media. I've had a few clients who've told me that if they were to post a picture on Instagram, their partner would immediately know where they're at. And so that's something that we're also seeing a little bit more with COVID-19. In terms of the epidemiology, in terms of the presence of it, one of the reasons why I think it's so important for us to talk about it is that it is hugely prevalent within our society, not only in the United States, but just worldwide. This data is actually from the US that says more than 1 in 3 women and more than 1 in 4 men have experienced rape, physical violence, and or stalking by an intimate partner in their lifetime. And as you can see here, the rates between women and men are pretty synonymous. The only difference is that people tend to think of domestic violence and intimate partner violence as a gender-based violence due to the fact that the frequency and severity, as well as the disaster outcomes, tend to be highly more prevalent for women, and that women are about 50 times more likely to die by homicide from an intimate partner compared to men. Within New York City, we do know, and this is data from before COVID-19, was that about 120,000 domestic violence reports that were responded to by the New York Police Department, again, responded to by the New York Police Department, was about 307 a day. And this was only in New York City. And so again, really just kind of highlights that domestic violence and intimate partner violence is out there, and that if you aren't aware of it, it's still there, and you will encounter it in your lifetime. Somebody else that you know will encounter it. But what we're seeing with COVID-19 is that we're seeing multiple publications and articles that are talking about the fact that it's rising during COVID-19. And if you turn to any paper, like once a week, there's some type of report of something happening, and not only in New York City, but again, worldwide for that matter. And I'd like to use this term, which was put out by an article most recently this year that talked about the rise of COVID-19 as being a pandemic within a pandemic. That there is a pandemic of COVID-19, but then within that, there's a pandemic of the rise of domestic violence, both intimate partner violence and child abuse during COVID-19. And one of the things that that the article highlighted, which I think Dr. Relaford also did, is that there are inequities in how this pandemic is affecting certain groups. And in particular, this quote that I pulled from the article, "This pandemic has reinforced important truths. Inequities related to social determinants of health are magnified during a crisis, and sheltering in place does not inflict equivalent hardship on all people." And this is true, in that what we're seeing is that certain people of color and people who are marginalized tend to be experiencing the brutality of COVID-19 more severely. And it really shows us that there has been an increase within New York City. The New York Police Department, again, before COVID-19, we're seeing about 307 reports a day. That increased by 10%. Calls to an organization that caters towards families with domestic violence, a 15% increase in calls. And what was striking about that was that 46% of those calls were new cases. And what the agency also said is that the severity of the older cases that we're seeing were much higher. So the clinical complexity was high, but then they were seeing new cases that it was affecting a whole host of new people. And part of it has to do with these pathways that are linking the pandemics of violence against women and children. Dr. Relaford talked about the economic fragility, the unemployment rates that have come about from COVID-19. But what the economics really determine is that people can use money and finances against the survivor. But more importantly, if a survivor wants to leave the situation, they need to be able to have economic support to leave. But if those resources are taken away, it makes it much harder. On top of that, there's a social isolation that tends to occur that's been occurring with COVID-19 that doesn't allow for families who need the support and help to reach out to somebody to get that help and support. There are increased family tensions where everyone's living at home. You know, at first it sounds great, but after a while, when you're living in an 800, 400 square foot apartment with a whole host of other people 24/7 for a year, and we're coming up on a year mark, it becomes even worse in terms of those family tensions that tend to bubble up and then can lead to more types of abuse, not only intimately, but also domestically. And then on top of that, you know, if you want to be able to leave the situation, where can you go? Because those services have been limited, or they're full, or they're limited because of the response to COVID-19. On top of that, the fear of actually, you know, if you were to leave, what would happen if you would be exposed to COVID-19, which definitely does kind of have that cost benefit analysis of what do you do. And then on top of that, there are reporting barriers. And what I mean by that is that we have these numbers that COVID-19 and domestic violence are on the rise, but I hazard that it's actually even higher than what's being reported. And that has to do with the less opportunity for reporting. And for children in particular, there's less opportunity for mandated reporting. And what I mean by this, as a physician, as a teacher, and anybody who's taking care of kids, they are mandated by the law to report any concerns of imminent risk to the child, any risk of abuse to the child. But when those children are not in school, they're not going to churches, they're not going to mosques, they're not seeing other family members, you know, those opportunities to be seen are less. And so there's less reporting that we're seeing. On top of that, within the medical profession, there's been a reduction in non-urgent clinic visits. So those well-check visits that we usually go to, they're being postponed. And so that also decreases the opportunity for a medical professional to lay their eyes on the child or the family, or even to actually offer some anticipatory guidance about what to do when there's tension in the home. And if they were to see the physician, and use of telemedicine also decreases the opportunity for safety and confidentiality. Again, if you're in a 400, 500 square foot apartment and the walls are thin, how can you tell somebody that you're in danger? And also unreliable internet and cellular service. And then what we're seeing right now is, and this is not necessarily new, again, this data is not necessarily new, is that what we're seeing is that there are more increased fears of calling 911, especially for our Black and Brown communities who have always had a fear of the police. What if you to call 911 and the police were to come, and you have to, again, it's a calculated risk. Are you worried about the safety of yourself or the safety of your partner who could possibly be killed and be on the news? And those are some concerns that our families have to deal with. In terms of what we're seeing in terms of how COVID-19 is being affected, I'm just gonna read a few quotes, and you guys will have access to my slides to get all of this data. But some things that are being used is that a caller said that they could not file paperwork to remove the abuser from their home because courts are closed due to COVID-19. A chatter mentioned that the abuser was using the virus as a scare tactic to keep the survivor away from their kids. And I've actually seen this too with a couple of my clients who are going through custody battles, that their partner would say, because you work in the healthcare field, you are not allowed to see your child because you are exposing more risk and danger to them because of the fact of the matter that you are an essential worker. And so that, again, it becomes a type of coercive control and tactic that is being used because of COVID-19. The chatter stated that had known for a long time that there were red flags in the relationship, but things are escalating with the pandemic and they can't even go to therapy. And this is definitely a concern when we think about what has been going on with mental health and domestic violence and trauma and COVID-19 and racial injustice. It has become this perfect storm where all this is becoming a melting pot, especially for our families who have these concerns. And individuals with trauma histories face additional challenges and feel the impact of COVID-19 more intensely. They have the triggering and reactivating past trauma symptoms and memories, that fear of not knowing what's going to happen, how long we're going to be in lockdown, the fear of not knowing what's going to happen if you step out of your home, the fear of not knowing if you're going to be able to talk to your loved one because it could pass away. As Dr. Relaford showed, certain communities are more likely to experience loss. And then being cut off from the coping strategies that have been so useful before. A couple of my clients have made comments saying, everyone is affected, I can't escape. And a lot of it has to do with the grief and loss, the loss of loved ones, but also loss of not being able to be what you wanted to do in your lifetime, especially for our young kids who are having to reimagine what it means to be a senior in high school. The anxiety of going through COVID-19, the acute and historical trauma that's being inflicted that we're seeing daily on the news, as well as addressing the mental health inequity and racial inequity that's been going on in our communities. And so all this to say is that the intimate partner violence is more than physical effects. We know that there's physical injury, chronic disease, but also there's mental health concerns, as I've already idealized and had mentioned that, and it's actually bidirectional, and that domestic violence can actually increase the risk of mental health, but also having a mental health disorder can also increase the risk of violence. And we know that PTSD is definitely a common symptom. We're about 5 times more likely to experience PTSD, but also depression, including postpartum depression when we think about our perinatal and maternal mental health. Being as a victim of domestic violence increases your risk of depression and postpartum depression by 4 times, increases your risk of anxiety by 3 times. And so it is something that we have to think about because it can lead to increased morbidity, but also to death in terms of homicide and suicide within our families. And so it's very important for us to think about this intersection and why there should be a call to action in terms of mental health and domestic violence, making sure that we can address the needs of DV, but also address the needs of those affected who have mental health concerns as well. And this is something that we're doing right now in the city of New York by taking on this integrated program and making sure our families who come into the Family Justice Centers, which allows for access to legal services, can also get access to mental health services on the spot. And we're doing this during COVID-19 as well. Some of the things that we've learned during COVID-19 to reach out to these families is to have these frequent touch points. And so instead of relying on families coming to us, we can call them or use AV, audiovisual technology such as Zoom or WebEx to reach our families when they are in need. And we're seeing that there's less no-shows. And what I mean by that is that they're coming to these appointments, that there is a need for them to come to these appointments, and we're able to see them more frequently and give them support that they wouldn't have gotten before. We try to be very, keep in mind the safety and confidentiality concerns, and recommending that clients find an appropriate time and location that works for them, that gives them the most secure privacy. So we had some clients who've done counseling in cars or gone for a walk. I'm really trying to achieve that clinician flexibility about being patient-centered. We recommend the use of headphones to increase privacy and determine if these conditions are safe and appropriate at all times. And then we also really just want to consider developing code words for privacy or immediate safety. So we want to do both, making sure if somebody says it's not a private setting, that we know how to address that, and also if they need immediate help, how to address it directly as well. In terms of, people always ask, what can I do as a loved one? If I'm concerned, what can I do? And you can do a lot. The mere fact of just being there and letting the person know that they're not alone is very, very helpful. Reaching out if you're concerned, if you haven't heard from somebody in a long time, just reaching out and checking in. Sending basic necessities if people are worried about food insecurity, being able to send them what they need so that they don't have to have that additional family tension. Interrupt or intervene if you see something happening in the moment. Oftentimes create a warm referral, like after you've seen this talk, and I have some resources at the end of the slide, offer them some advice about what to do. Creating virtual or physical respite if their kids in the family are causing tension. Maybe the kids need to be taken out of the home or need to be indulged in some other way. And really thinking about the power of your relationship, that there is that intimate relationship that you have that can allow to words of encouragement, and also letting them know that by you taking care of yourself, you're also showing that they can take care of themselves as well. And all throughout this, I really want to impart there's a lot of resilience and hope. So despite the fact that I'm talking about the rise of DV, we're also seeing that people are able to leave their situations if necessary. And that there is hope, that trauma does not define a person, mental health disorder does not define a person. And there are creative ways to connect and support others and ourselves. Remind yourself or your loved one that how to get through these past traumas, and that people have survived. And you are here because you're a survivor. And there's this quote I like to end with, if you're born with the weakness to fall, you're born with the strength to rise. That COVID-19 has definitely put a damper on all of our lives, but we've also learned so much from COVID-19 in terms of what we can do, what we can achieve, and how we can move forward and survive. Thank you.
Well, thank you, Dr. Rutherford and Dr. Berry, for a very comprehensive presentation. So any question from committee members?
I see Rich Mintz has his hand raised.
I do. This question is for both of you, but I'll address Dr. Berry because you were the one talking about family violence. In my professional life, I work with the violence prevention and victim assistance offices at Rutgers University, which are funded by the state. And one of the things that they have said is that the uptake of their services has been reduced since campus went remote, in part because people who find themselves in a situation of vulnerability may not feel safe to reach out while they are in a home, possibly with someone who's the cause of the violence. And as a result of that, they're expecting an even bigger uptick in demand as things open up. Do you expect that more broadly, culturally, and in the public system here in New York?
I do, and I think it's twofold. And one is that I think that for a long time, people usually thought about domestic violence as something that was private and shouldn't be talked about. It had a lot to do with stigma and oppression. And I think what we're seeing is that the media and the way that the generations are thinking about it is that it should not be silent. Even though you may feel silence, you should not be silent. And there's a need to really push out the message. And so there's been a big call to try and get people access to those services and know that there are services available. And so when things start to open up, I do expect to see a big increase in people seeking services and wanting to get help and realizing that this is no longer sustainable and that they need some support. So I do see that.
Is there anything we need to do as a community advocate to ensure that the resources are in place 3 and 6 months from now as demand starts to tick up? Or is that sort of naturally handled by the budgeting process and so forth?
Yeah, I think, I view this as a public health issue. And when you think about a public health issue, it shouldn't only be limited to one department. It should be a community response. And so you'll have access to my slides, which has a whole bunch of resources, but I think resources should be available to anyone and people should have access to them. So even if and again, because 1 in 3 women and 1 in 4 men, you will encounter somebody. And so if you know where to direct them to, that would be great to be able to give them that information when they're ready to achieve that. And so hospitals can do that, but even just having some in the grocery store, in the pharmacy, that was something that they had done in France, actually, by having like a code word for people to enter the pharmacy and say, I forget what the code word was, but once they said that, then we're given access to these services. And I think that's something as a community we can figure out to do to be able to provide that prepare for that surge that's about to happen. We can also do more media pushes, TV ads, but also, the NYC mayor's office does pushes on your phone. When they talk about COVID-19, they could do that for DV, that our services are there. And we need to make sure that these services are available not only in English, but in other languages as well. Because we want to make sure that people have access regardless of their income, regardless of their race, regardless of their language spoken.
Yeah, I just want to add on Rach's question. So as community board, what do you think we can do to increase reporting and reduce the impact in general on mental issues due to this pandemic?
I'll start and I'll turn it over to Dr. Relaford too. I think that what you're doing right now is awareness. I mean, if people don't know, then they're not going to do anything about it. So really kind of building that awareness. And so I'm very thankful and fortunate to be here to talk about the work that we're doing to kind of spread that message across. And then empowering you, the community board members, to know how to reach your community by providing these resources, providing an outlet that you can come reach out to me. And I'm sure Dr. Relaford also agrees that if people have questions, to know that you're not alone in dealing with this. It should be a community affair.
Well, absolutely. I mean, just to add, I would say that doing just this, raising awareness of the mental health issues. I mean, most people during COVID, they are experiencing their own isolated experiences. There's less community, there's less engagement. Folks are not at school. And one of the things that I have found as a challenge in Brooklyn as well as in Manhattan is that it's really hard to reach the kids who may be struggling with these increased rates of depression, anxiety, or trauma because they're not at school. They're at home with their cameras turned off, or they're actually not engaging in school or going to school at all. There was some data recently that showed that there was an increased rate of suicide attempts in a little bit of the higher adolescent age group. And those are individuals primarily that were not engaging in school, right? And so those are the ones that we really need to reach. And I think that continues to be a challenge, but I think Department of Education has really been stepping up education efforts, as well as we in our own institutions have been doing the same.
Yes, I totally agree with increasing awareness. And with this committee meeting, like we only have 14 participants. So if we plan to do a health forum, can we again invite both of you to do this presentation?
Yeah, absolutely. Count me in.
Absolutely.
Thank you. Yeah, so we might do that. We're gonna discuss today, but we might do it in May. So at least we can invite more people to come to the health forum. Thank you very much.
No problem. Thank you.
I see that Marty has his hand raised.
For a number of years, there was a growing interest in peer-to-peer counseling, and that actually my wife wrote a book for SAMHSA on it. But anyway, the individual, there's a stigma both culturally and also age-wise, and that younger people don't necessarily trust older people to tell them how they feel. Having their peers as doing outreach has had a lot of success at the time when my wife was writing her book. But is the city or NYU doing anything in regards to encouraging young people to participate as far as a reach out? You know, kids may not be looking at you know, in school, but they're always texting, they're always gaming. There's a lot of areas where a young person can reach out to somebody who is having problems. Has there been any anything going on in that realm?
I've heard of one such program formally in New York City. I'm sure there are others. Warren Eng, who's one of mine and Dr. Berry's colleagues, he has a community program in Washington Heights at Columbia that is very much a peer advocacy program that actually does sort of what it is that you're describing. I think that the advocacy efforts for mental health in the schools and otherwise has shifted a bit, right? I mean, I think that certainly there's a lot of education about mental health and really highlighting the importance of it. But I think some of the shift has been to having peers be allies, students be allies for their peers, and to be able to talk about situations in which there are challenges for their peers, helping them to get resources and getting them plugged into care potentially through local resources or otherwise. So I think that's certainly important. I think you've highlighted another thing, which is that stigma within particularly low socioeconomic, underrepresented minority communities or non-white communities in general, immigrant communities, is really high for mental health. And I think that's a huge challenge that we face every day in trying to get folks to come in, to get help, be evaluated for help, to take the help when it's actually recommended, to continue to be engaged in treatment once you've actually had the evaluation and recommendations. And you're going up against a lot there. And that continues to be a huge problem.
One other comment in regards to domestic violence. There used to be programs in beauty salons where women would feel safe to be able to discuss that they're having problems. There had been a program throughout New York City in the nail salons, in the beauty salons, for identifying women who were having these issues. Also, I had heard in some places they are pizza parlors had code words for domestic violence, because anyone can call a pizza parlor and not be afraid that their partner is going to attack them for ordering a pizza, but there had been code words for that.
Yeah, no, absolutely. The initiative you mentioned with the beauty parlors was an initiative put out by the mayor's office a few years ago to really kind of train and educate the staff to know how to respond and identify concerns around domestic violence, and also bring that awareness to the team and provide that safe space. Because the real issue is making sure that people feel safe and ready to talk. And sometimes people are not ready, but making sure that there is this avenue for them to do so, and being ready to have that open up. In addition to the pizza parlors, that's also something. But the tricky thing is with COVID-19, all those things shut down. And so it was a creative solution at the time, but now we need to figure out what to do in the midst of COVID-19 to kind of also create that safe space for people to reach out.
I think we have one more question. Andrew?
Yeah, hi. Firstly, thank you so much for coming and speaking to us. Both those presentations were incredibly interesting, and I look forward to being able to reference those slides. I actually had a question with regards to really access to this care in terms of insurance. So obviously with unemployment rates spiking, a lot of people being pushed off of their private insurance, I was curious as to, for people who are looking to get access to behavioral health services, what kind of resources would be available for those who are uninsured, or do you know what would be a good, or like just generally like what resources would be available for those who are, who don't have access to health insurance right now because they're laid off or whatever the situation might be?
Yeah, I mean, absolutely. Again, that's another health inequity, and especially with mental health, being able to pay for services. And in New York City, which is, there's a disparity in wealth. And so because of that, how people have access to good care can be kind of different across those socioeconomic gradients. I think that most academic institutions try to do a good job of providing some of that resources to people who have lower socioeconomic standards. Within New York City itself, there's Health and Hospitals, which is the largest public city hospital in the country, and provides care to those families who cannot otherwise pay, including people who are undocumented, who do not have insurance, and whose insurances have lapsed or have lapsed because of COVID-19. And particularly with our work with DV, the mayor's office provides free services to people, again, regardless of age, race, and income, what you name it. And so again, just getting that message across that if you don't have the resources, it is okay. You'll be able to be taken care of. And I think it's a really important part to talk about it because, if we don't take care of our most vulnerable, then even our most successful are going to suffer because of that. It's just not the best way to think about how we provide curate humanity, for that matter. And, I think Dr. Relaford can speak a little bit more about the child mental health services, and that, people are really trying to figure out ways to do that. Another number is 1-800-NYC-WELL, which is a number from the mayor's office and NYC Thrive to provide rapid calls to anybody who's experiencing mental health concern, adults or children, to call. And you can also, I think there's also an ability to text. And that's a free service too.
Yeah, New York City Well was exactly what I was going to refer to. In particular, even though there can be challenges with parents being unemployed and getting insurance, kids, it's not as challenging of a situation compared to adults. And so there are a good number of community mental health clinics. So for instance, I used to work at VNS Visiting Nurse Service Friends in the Bronx, as well as our clinic down in Sunset Park, the NYU Langone Brooklyn Sunset Terrace location, and many other locations, Kings County, elsewhere, where you can go and seek services, and you can either get enrolled into an insurance that's going to help you to get care, or they will be able to offset your ability to pay. So it's all hope is not lost if you're not, if you as a family member who's providing for your family has lost your job and your insurance, you can still get care.
Thank you.
Any other question from committee members?
I do not see any.
My wife was the OMH liaison to Friends. Know it well.
It's a great organization in New York City. I miss working there.
So if there's no other question, again, thank you so much, Dr. Relaford and Dr. Barry, for a very comprehensive presentation. And we look forward to your participation in our future activities.
Definitely.
Thank you.
Great. Thank you for having us.
Thank you. So now we're going to go to the chair's report. So I have one report. The health department released the latest childhood blood lead level surveillance quarterly report. And this covered the first, second, and third quarters of 2020 from January through September. And the number of children with elevated blood lead levels in the 3 quarters went down from 2,970 in 2019 to 2,218 in 2020. And this is due to underreporting of cases that is attributed to COVID-19 pandemic. So to promote the need for blood lead level testing of children during the ongoing COVID-19 public health emergency, the health department has issued guidance to healthcare providers promoting the need for testing at routine medical appointments, and has seen mailings to families who had a child that missed their 1 or 2-year-old test, urging them to make an appointment. And additionally, the health department nurses continue to monitor the New York City's childhood blood lead registry every day and make calls to families and healthcare providers of children who have a blood lead level of 5 micrograms per DL or greater, to remind them to set up and keep appointments for the follow-up testing. As we know, New York City has one of the highest testing rate in the state. 80% of New York City children are tested at least once before their 3rd birthday. And the health department collaborates with the Medicaid managed care plans to improve testing and issues manual reminders to healthcare providers. That's all my report. So now we're gonna go to any old or new business.
Well, I have a report a little bit. Professionally, I manage a trade association for voluntary organizations that support people with developmental disabilities. We have 160 members and they take care of about 90,000 people in the downstate area. Obviously, these organizations have a huge census of staff, and in general, only 20% of the staff are getting vaccinated. It's a real problem. A lot of it is cultural. You know, on the news earlier today that the 33% of the nation that is refusing to be vaccinated, many of them are young people, and many of them are people of various minorities, which tend to make up the workforce of the individuals who are caring for people with developmental disabilities, as most home health aides tend to be younger and or people from immigration status. It's a real problem. A lot of outreach has to happen. I had made a suggestion at one of our meetings to promote the Tyler Perry advertisement that he put out. He did a 30-minute of talking about it and showing his own vaccination. He did it as Tyler Perry, not as Medea, but he's a big influencer. Unfortunately, even those agencies that used that, they weren't that successful in increasing their staff's participation. Real problem.
Yeah.
Like
So
one agency, for instance, they run a clinic. They had 4 doctors, and the 4 doctors all took the vaccine. They have 17 nurses, and only 2 nurses took the vaccine.
yeah, it is a problem.
Yeah,
And as community members, what else can we do?
good question. The city certainly is doing a lot of outreach.
So we did a town hall meeting on vaccine hesitancy in January.
It was great.
So do you think, as part of the new business, I would like to share about what would be your opinions about organizing a health forum? And I'm looking at May to do this. So as members of Health and Human Services, what do you think?
Who would our audience be for that?
We will be inviting members of the community.
I guess what I'm asking is, would we want to try to reach out beyond our own geographic area to other parts of the city?
Yes, we did
Okay.
within our district and probably the other community boards, because it's not going to be just a plain town hall meeting. It's going to be a health forum. So that will that encompasses a greater number of people than just doing a meeting or a town hall meeting.
The board
Yeah.
office has a huge mailing list.
Yeah.
Huge mailing list. I mean, it can really get out to a lot of people.
Right. So
And if we partner with, say, HHC, for instance, then it's even a greater reach. Certainly, Bellevue is very much the middle of our board.
Yeah, that's kind of what I'm thinking of. Like, how do we get outside the constituency of people who are tuned into the community board? Because I think on the whole, we're not the people with vaccine hesitancy, or and we are probably more informed about some of these issues than other people in the community.
Yes, absolutely.
Yeah.
So,
CB6 used to have an appointee to the Bellevue CAG. I don't know if we've done that anymore. We would have appointees on all the various organizations in and around, like the community development organizations.
We have had people on the cab in the past. I've been to meetings, but I'm not on it now.
that's right. Rich is it not 2 years ago you were assigned as representative of health and education?
Yeah, but I think I got taken off.
Oh.
I've been to one. I've been to a couple of meetings, but we had like 3 people going.
So how can we
Let me see who's go. I'm going to make a note here to see who is going, and if no one is going, I'll make sure that I go.
Okay.
The board needs to appoint you.
Okay.
So speaking of the board, I see that Kyle, the board chair, has his hand raised and has had his hand raised actually for a few minutes.
Oh, okay. So let's give the floor to Kyle. Kyle?
Hey, everybody. Thank you. So just kind of going to the original point that Marty was making about, reaching out to people. So as Elvie mentioned, we've actually been sharing the original town hall with as many of our, networks as possible to make sure that that information is getting out to everybody. So we have heard a lot of positive feedback for that. The hard part about all of this is that it's a two-way street. We can always give out as much information as possible, accurate and reliable information, but there is this sense of like there needs to be the other half, the partnership of following the information and taking the proper steps. So we've been doing that. And I think as you think about another program, there are a couple of things you have to keep in mind, some of which have already been brought up, which is who specifically is the audience. Now, as we think about committee work and board work, I think we should always be thinking about the district first and then expanding from there. And I think in virtual programming now, sharing our resources, even if it's district specific, allows us to still expand throughout the city as well. So we can do that on our end of actually sharing it with the relevant stakeholders. So, so with that, I would actually kind of examine within the district where there is vaccine hesitancy. If there is a connection between, ethnicity or economic level, educational level, et cetera, then we can hyper focus on those areas and figure out how do we want to reach to those specific groups. Do we want to co-host with a specific organization? Or for example, if, and I don't know the stats off the top of my head on this, but say that we see that a lot of NYCHA residents are hesitant to take the vaccine, maybe we co-host with one of the tenant associations, organizations over there, and have them kind of do outreach to their tenants to attend the town hall or the forum or whatever it ends up being. So I think there are things that we can do, sort of like take that approach where we hyper focus within the district, because kind of thinking citywide, there's a lot of different issues that go into it that might be too overwhelming at first. But if you start hyper local and then expand from there, I think that's a much better approach. In relation to the cab, we do have someone who goes there. I can't remember at the top of my head who it is, but I did not remove Rich, so I'll double check on that on our end who the assigned person is. Yeah.
I haven't received any communications about it in months, and so I assumed that I'd been taken off.
No, so I'll double check on that and see who we had. Pretty much whoever was the representative on the cab associations as I came on has remained the same, except for people who told me that they were dropping off. So let me double check on that and I'll get back to Elvie and Rich on that.
We used to have 3 spots.
Yeah.
And then just the last part as you're planning as well. The other thing that I would keep in mind as well, as you put together a health forum, is to remember the news that we heard yesterday, which is that Cody is no longer with the office. So the board staff will have a lot on their plate going forward. So as we think about this, it might mean that we need more heavy lifting from more members of the board, or sorry, more members of the committee, to ensure that, you know, our board staff isn't overwhelmed and being asked to do 10 different town halls and meetings and all of that at the same time. So I just want to keep that in mind as well.
Yeah, thank you, Kyle. Well, when I was thinking about the health forum, it's not just one topic. So I'm thinking of several topics like the long-term effects of COVID, then these mental health issues. I mean, it's good to increase awareness, not just for our members, but also for, you know, the members of the community, and probably include other community boards. So, and I was also thinking about, I was thinking of one more thing.
Well, I would just based on that, my advice, and again, this is up to the committee, but I would stay away from doing multiple issues at once. And it kind of has to go back to like what you want to get out of the health forum. If you're thinking simply kind of like a resource fair where like, hey, these are the appropriate agencies, these are the appropriate resources, etc., and here's a brief overview of what they do. Now you go connect individually to get your information and to share your circumstances. That's one thing. If you're trying to information share, if you're trying, especially online, trying to keep people's attentions, trying to keep people focused on a specific topic, or drawing the right audience to come for the specific topic that you're talking about, it might be too broad. It might actually hurt your outreach if it ends up being too broad. So if you want to focus on a specific topic, I probably think that's a much better way to go about it.
If I can say something, so if the purpose of the panel or the forum itself would be to disseminate more information and awareness about the vaccine distribution, like addressing vaccine skepticism, potentially among other things, to Kyle's point, I don't know if we're going to be reaching the most vulnerable populations who would need to hear that message just through a forum itself, / would have like the connections to know to come to this kind of a panel. I attended an event last month also on vaccine skepticism, and what the one way that they approached it from like the representatives on that is talking about volunteering to help people sign up for vaccine appointments. I think that is this is also, of course, like if you are comfortable enough to do that, and if you're not at a high risk population, there's a lot of other like stipulations that come with it. But I think on the ground work like that, like basically going to they're specifically targeting like low-income communities, those people, and senior communities, people who might not have access to technology, don't know how to sign up for an appointment, might need guidance to do so, might not know where to go, whatever it might be, people who might not have internet access. So if we can do something that's a little bit more on the ground active like that, I think it would also be very beneficial. And maybe that could be just be within our community board, maybe it could be partnered with another one. But I think like alternative to a forum, just because I think we've had so many of them, maybe it's just me, I think this is an alternative of how we can accomplish what we're trying to do, and that is making sure more people get vaccinated who are eligible and high risk.
Yeah, and remember that some of our elected officials are doing things on the ground. So we heard, for example, Councilmember Power's office is doing the pop-up COVID testing in Stuytown. So there are things that we could do that as well. Again, it kind of like there needs to be some research, and of course the committee needs to discuss this as well, is, you know, do you want to first examine within the district which populations are most vaccine hesitant or are not getting the proper information, et cetera. And then maybe, you know, focus on working with those specific communities, whether it's through an organization, maybe faith-based institutions as well. You know, a lot of people trust the information that they get through their temple or their church or their mosque, whatever it might be. there is opportunity for partnerships there for us to maybe work with an elected official on that organization to, going to Anju's point, like tabling, kind of maybe going back to basics, and saying, hey, like here's information, or if you have more information, maybe call in some of the agencies as well to do something on the ground in person, or just simply with that organization to that specific community. So it may not be a quote unquote forum, but you're doing specific programming and targeted outreach to those communities virtually, and having an array of speakers to say, hey, this is this is what you may be hesitant about. This is answering those specific concerns.
Yeah, I think, but my intention for the health forum is not to disseminate resources or information. My intention was to increase awareness that will cover more people. So it's not, we have so many ways to disseminate information, and we like the social media and in our television, we have so many information about resources, but that's not my intention for the health forum. My intention is to increase awareness that will be shared for more people than just to 10 members of the committee.
No, I get that. And again, these are just prompts and feedback. This, of course, goes back to whatever the rest of the committee decides to do. But it goes back to the basic question: if it's about if it's about awareness, are we being redundant in our efforts? If the city, the state, the president of the United States is, consistently, making, outreach campaigns on awareness, is that more effective? Is it more effective for us to maybe piggyback off of what some other people are doing? And we've done this in other committees before. Just to give an example, when I was on BASA, we were trying to educate business owners and consumers about what was, their responsibilities, the health precautions and all of that. And we were going to create our own outreach campaign on it, and then realize that there was an outreach campaign that the city was doing. It was just not really well done at all. And so we kind of took their materials, we took, pulled in their staff and speakers and said, hey, can you, here are our local businesses that need this information, and directing them in terms of awareness that way. So there are a lot of options on the table here, but, you just kind of have to think through, are we doing a forum for a forum's sake, or is there a specific reason, or is this the specific strategy that we need to take to address a certain problem? Because if it's just simply to do awareness, or to just to, I don't know, share resources or whatever it might be, you might not get the audience you want. You might not have the impact that you think you might have. So I'm just offering feedback and just prompts for the committee to think about as you decide what to do going forward.
Yeah, but I think what you're talking about, in order to address that, is by doing first a needs analysis, which is a lot of work.
Exactly.
For all, how many members do we have, and who's gonna do? Because we cannot, in order to address what you're saying about, we have to do that needs analysis, and who's gonna do that?
Well, no. So that's the work of the committee, right? So remember, you don't have to do something right away. You did do the town hall in January. Remember, things are constantly changing. So even the information that you talk about in the health forum in May might change a week later, might change the month after. I think a lot of this also has to do with the accessibility to vaccines. I think it's kind of hard for people to even care about taking a vaccine if their appointment is not for a couple of months, or we keep hearing in the news that there is no supply. So it's kind of like, even if I'm ready to take the vaccine, I still have to wait like 3-4 months to actually get it, and then take my second dose, or if I'm taking that vaccine. So this can be kind of the work of the committee, actually, which would be interesting in terms of, not just for the vaccine, but maybe health needs in general. We've seen other committees do maybe like surveys, and maybe you get a health survey of all of the specific needs, maybe not just vaccine hesitancy, but some of the other things that we've discussed here today as well. So that we can then hyper focus on a lot of these issues and do targeted programming rather than just general programming, and not really knowing who exactly is going to be attending, or who we're trying to reach, or what type of result or conclusion. And again, just sharing my thoughts on it. This is a committee discussion, so.
Any other opinions?
Piggybacking off of one of the ideas posed, which is tapping into as well the work that's being done by like city council members within our community board to reach out to those like high need populations as well, seeing if we could, seeing if they've, I think it's one thing as well to do our own like needs analysis. There's value to that, of course. There is that would require a lot of upfront time to conduct that properly, but seeing if there is other work that's being done by elected officials within our jurisdiction that they've identified like certain populations, and even if not like a formal survey, like they are, whether it's like out and about virtually or like in real life, seeing like which communities are in highest need that we could potentially support. So doing it a little bit more informally and just like checking in with our representatives to see what they identify is communities that we could be targeting is I think one potential outlet as well, and maybe even like supporting or seeing if the way we can partner in those efforts. It might get tricky because primaries are coming up, so I say that cautiously, but I'm thinking that's a way that we can talk. Elected officials should know what's happening in their district and who's most impacted. So as a knowledge base.
I think that's a great idea. So you want to take the lead on that to do some research if other.
I can reach out to the city council members in CB6. So like,
That's good.
Yeah, Powers, Carlina.
Any other comments? Any other new business? Okay, so I think it's about time to end the meeting. I would like a motion to adjourn if there's no other question.
So moved.
All right, so so that means that seeing no further business, the meeting is adjourned at 7:57 p.m. And thank you so much, everyone, for coming to the meeting. And hopefully we can talk more about the future plan that we want to organize in our next meeting.